the field of clinical practice, there are a number of diseases that can only be diagnosed by using either a lab investigation or an imaging. Now, there are some diseases where we can diagnose them by using our clinical skills. Which brings us to the topic of our discussion, disorders of pleura, where the disorders of pleura can be diagnosed by using basic clinical skills like auscultation or percussion. Now, pleura is a space between the lungs and the chest wall. This pleura has got two layers, a visceral pleura and a parietal pleura. Visceral pleura is on the lung side and the parietal pleura is on the thorax, that is the chest wall side. Between the visceral pleura and the parietal pleura, there exists a small amount of fluid called as a pleural fluid. Now, the amount of the pleural fluid is generally somewhere less than 25 ml. Now, this pleural fluid is produced by the small capillaries. These capillaries produce the pleural fluid, which are responsible to reduce the friction when the lungs expand, which helps in the coupling system, acts as a coupling system when the lung expand. Now, this fluid that are produced from the capillaries, which are present in the pleural cavity, are absorbed by the lymphatics. Now, the lymph absorbs the pleural fluid. So, a balance is always maintained between the production by the capillaries and the absorption by the lymphatics. So, this pleural fluid, as I told you, is usually somewhere less than 25 ml. So, whenever the collection in this pleural cavity increases, there is an accumulation of fluid which is more, which leads to pleural effusion. So, this accumulation of fluid can occur as a result of either an increased production from the capillaries or a decreased absorption from the lymph. So, this pleural cavity, which generally has a pleural fluid, if there is a collection of excessive fluid in that pleural cavity, it is called as pleural effusion. If there is a collection of air in that pleural cavity, it is called as pneumothorax. If there is a collection of blood in the pleural cavity, it is called as hemothorax. And similarly, if there is a collection of milky fluid or a chylous fluid, it is called as chylothorax. So, we discussed anatomy and the physiology of the pleural fluid. Now, apart from the capillaries, which are responsible primarily to produce this pleural fluid in the pleural cavity, from the interstitial spaces of the lungs, fluid can enter the pleura. That is the visceral pleura. From the interstitial spaces of the lungs, the fluid can also enter into the pleura. And from the abdomen, even from the abdomen, there are small holes in the diaphragm. Whenever there is a large ascites, or whenever there is an abscess, or whenever there is a pancreatic disease, there is a collection in the intra-abdominal cavity. This fluid from the intra-abdominal cavity can get transmitted into the pleural cavity from the small holes which are present in the diaphragm. So, the point here is, there is a pleural cavity where there is normally a pleural fluid which acts as a coupling system, which is governed by the balance between the production and the absorption by the lymph. But there are various spaces through which fluid can get accumulated in the pleural cavity, either from the interstitial space of the lungs or from the abdomen through the holes of the diaphragm. So, these lymphatics usually have a capacity to absorb 20 times more fluid that is formed. So, what does that mean? So, whenever there is an escape of fluid into this pleural cavity, lymph has got a capacity to absorb it to a higher level. So, usually there has to be an abnormality in the increased production which has to exceed the rate of absorption via the lymphatics. Only then there can be an accumulation in the pleural cavity. So, either a defect in increased production or a decreased removal can lead to an accumulation of the pleural, that is pleural effusion. So, how do you diagnose an individual with pleural effusion? As I told you, first and foremost is a clinical symptom. We will discuss the symptoms and the signs that an individual with pleural effusion in the coming slides. Usually, an individual who is presenting to you with a pleural effusion will primarily present to you with a disease that has been affected. Once there is a collection of fluid in the pleura, If the collection is mild to moderate, usually the symptoms arising exclusively out of a fluid collection is rare. But sometimes there can be an occurrence of constitutional symptoms such as fever, fatigue, night sweats, or even pleuritic chest pain, which is specifically associated with the change in the posture or during deep inspiration. Apart from that, there can be clinical signs, that is a reduced air entry, and typically a finding which is percussion. On percussion, there will be a dull note of the affected side, while the other side will be a normal resonant percussion. So when you, apart from the clinical examination, the next investigation you would get is a chest x-ray. When you get a chest x-ray, the first and the foremost sign is a obliteration of the costophrenic angle. So this is the diaphragm, and the angle formed between the diaphragm and the costal margin is called as the costophrenic angle. So whichever side is affected, the first and the foremost sign is the obliteration of this angle. So whenever there is a increased fluid collection in the pleura, this angle is obliterated on a chest x-ray. When the collection exceeds, then it forms a fluid level. So to form a fluid level, there has to be a collection of more than at least 200 to 250 ml. If there is a smaller collection, there is an obliteration of costophrenic angle. If there is a larger collection, you can see a fluid level. Next investigation is to get an ultrasonogram of the chest. Now, ultrasonogram can not only diagnose the presence of pleural effusion, it can also quantify whether it is a mild effusion, whether it is a moderate effusion, whether it is a large effusion. Along with that, it can also tell you the level of pleural effusion, and it can also give you the marking. It gives you a marking that below this level, you can puncture and do an aspiration of the pleural fluid. So USG chest is not just diagnostic, it can also be used to remove the pleural fluid, that is thoracocentesis. And contrast enhanced CT can be done to find out the exact etiology of pleural effusion, whether it is of a heart failure effusion, whether it is an exudative cause, or whether it is arising out of a malignancy. Apart from that, you need to get a serum protein and LDH along with a pleural fluid analysis to find out the exact etiology, whether the pleural fluid is going to be an exudative origin or a transudative origin. So these both images are showing you of how a thoracocentesis or a thoracentesis are done. Both terminologies are the same. Here, you will either a diagnostic or a therapeutically, you remove the pleural fluid that is accumulated. So in the first figure, as you can see, there is an effusion on the left side. So if the effusion is large, then there is no need to mark it with ultrasonogram. But if you feel the effusion is mild or moderate, that has to be marked with an ultrasonogram, and that point is the point below which you can find or you can puncture and get a pleural fluid. So either in the mid-axillary line or the posterior axillary line, anywhere between the 7th and the 9th rib. On the upper border of the lower rib, you can use a 21 gauge needle and you can puncture in the intercostal space till you get a pleural fluid. Once you get a pleural fluid, you connect it to the three-way, behind which you have connected a 20 cc or a 50 cc syringe, depending upon whether that thoracocentesis is a diagnostic one, where you would just want to collect the pleural fluid for analysis, or whether it is a therapeutic one. That means that you want to remove more of the pleural fluid for a therapy. As a cure, you want to remove all the collection so that to relieve the symptoms of pleural effusion. Depending on that, you drain the quantity of pleural fluid. So the three-way is connected to the needle, a 21 gauge needle which is going into the pleural cavity. On the other end, it is connected to a 20 cc or a 50 cc syringe, and on the third way, it is connected to the 150 cc which is going and forming in the draining chamber. So prick on the mid-axillary line or the posterior axillary line between the 7th and the 9th rib on the upper border of the rib. Why the upper border of the rib? Because on the lower border of the rib, there is a accumulation of arteries, veins, and the nerve. The neurovascular bundle is present on which runs along the lower edge of the ribs. So you should never puncture the lower end of the ribs. So always puncture the upper end of the lower rib. So once you get thoracocentesis, next is to evaluate. Now, what all investigations you need to get from that pleural fluid? Send the pleural fluid for complete microscopy. Send for biochemistry. In biochemistry, you're going to evaluate for glucose, pleural fluid protein levels, pleural fluid LDH levels. Now, once you get a pleural fluid protein and LDH levels, you also measure for serum protein and serum LDH levels. After that, you need to follow this protocol. If any of the three following criteria is met, then that fluid is exudate. Now, what are those criteria? Get a ratio of pleural fluid protein to serum protein. If the pleural fluid protein to serum protein is more than 0.5, or if the pleural fluid LDH or a serum LDH is more than 0.6, or if the pleural fluid LDH is more than the 2/3 of the upper normal serum limit of LDH, if any of these criteria is fitting, that means that the effusion that you have got is of exudative. And usually it is the local cause that is leading to an increased production of pleural fluid or a decrease or a defective absorption. A local cause of pleura is the one which is causing this exudative pleural effusion. If none of these three criteria are met, so then that means that the fluid that you have aspirated is transudative. So that means that it is a systemic disease which is causing either an increased production of pleural fluid or a defective absorption of pleural fluid. Systemic disease commonly are either a congestive heart failure, a left ventricular failure, or a cirrhosis or nephrosis. And once a diagnosis of exudative is made, the next investigation is to find out what is the local cause. There are n number of local causes which can lead to an exudative effusion. The most commonest cause are usually a bacterial pneumonia, a malignancy, or tuberculosis in our country. So once a diagnosis of exudation, that is exudative pleural effusion, is made, next step is to evaluate the glucose level of pleural fluid. If the glucose level is less than 60 milligram, that means that it is usually a bacterial infection or a malignancy is the cause. If you feel that you need to differentiate from a bacterial infection and a malignancy, you need to do a fluid cell cytology. If you are able to evaluate and find the malignant cells, then the diagnosis is malignancy, or depending upon the total leukocyte count and the cell count and the WBC count, you can diagnose it as a bacterial pneumonia and a synpneumonic effusion. If the glucose level of the pleural fluid is more than 60, then still there is a possibility of tuberculous pleural effusion. If there is a possibility of tuberculous pleural effusion, then you need to evaluate for ADA levels. ADA levels more than 40 international units per liter is likely to be a tuberculous effusion, or that fluid can be sent for CB-NAT or even for culture. So what are the causes of transudative effusions? The most commonest cause of transudative effusion is congestive heart failure. Any heart disease, be it a coronary artery disease, be it a valvular disease, or be it any pericardial disease which has ended up in a congestive heart failure or a left ventricular failure, will lead to an increased accumulation of fluid in the interstitium. Now, as I told you, whenever there is an increased accumulation of fluid in the interstitium, that is interstitial spaces of the lungs, this fluid from the interstitium can enter the pleural space via the visceral pleura, and then there is accumulation of pleural fluid. Typically, a heart failure effusion will be bilateral. Other causes are cirrhosis, nephrotic syndrome, peritoneal dialysis, mixed edema, or even rarely, which is seen in superior vena cava obstruction. Moving ahead to the exudative causes of pleural effusion. Here, as I told you, any one of the three criteria are met. So, the most commonest cause of exudative pleural effusion is infections. Infections can be either bacterial, viral, fungal, parasitic, and in our country, most importantly, tuberculosis. They can arise as a result of neoplasm. Most commonly, it is usually a metastatic malignancy of other sites or other organs, or rarely from a mesothelioma itself. Rarely from a collagen vascular disease such as rheumatoid arthritis or systemic lupus erythematosus or drug-induced lupus can also lead to a formation of exudative pleural effusion. And from gastrointestinal diseases. Diseases of pancreas, a chronic pancreatitis can also lead to a formation of exudative pleural effusion, or intra-abdominal abscess. An individual who has recently got a liver transplantation or any form of intra-abdominal surgeries can lead to a formation of exudative pleural effusion. And exposure to radiation or certain drugs such as nitrofurantoin, methysergide, amiodarone, and exposure to bromocriptine. Then there comes miscellaneous causes of exudative pleural effusion, which can be uremia, sarcoidosis, or an iatrogenic injury, or Meigs syndrome, which is a benign ovarian tumor with ascites and pleural effusion. This is a chest X-ray of an individual who is suffering from a left ventricular failure, leading to a congestive heart failure and a pleural effusion. Here you can see there is a occurrence of bilateral pleural effusion. Both the costophrenic angles are obliterated. Along with that, one contrasting feature is a presence of cardiomegaly. Left margin, that is a left ventricular apex, is not seen in this X-ray, which is obliterated by the collection of fluid on the left side. So this is how typically an individual suffering from heart failure will present to you. This is a chest X-ray of an individual who has presented to us with an exudative pleural effusion. On an PA projection, what you can see here is an obliteration of costophrenic angle of the right side. Along with that, there is a homogeneous opacity involving the middle and the lower lobe. And when you get a lateral X-ray of the same individual, what you can see is a fluid level. If you see this X-ray in a posterior anterior projection, you would feel that the accumulation is very minute or minimal. When you expose the individual with a lateral X-ray, you can see that the collection of fluid is much more than minimal. Also, after the advent of and the use of USG, lateral X-rays are no more prescribed. Now, as I told you, malignancy are the second most commonest cause of exudative pleural effusion in the Western world. In our country, first most commonest cause is a bacterial pneumonia, forming a parapneumonic or a synpneumonic effusion. The second commonest cause is a tuberculous effusion, which is responsible to cause an exudative pleural effusion. And the third cause is malignancy. Now, as I told you, malignancy is usually a metastatic cause, a malignancy of an other organ causing metastasis and an exudative pleural effusion, or rarely a mesothelioma. Now, 75% cause can be either a lung carcinoma, a breast carcinoma, or lymphoma. It means that 75% of the times where there is a pleural effusion because of malignancy, it can be either a lung, breast, or a lymphoma. Fluid cytology can be easily be used to differentiate and find the malignant cells, because when you find out that the effusion is exudative, the next step is to get a fluid glucose. If the glucose is less than 60, that means that either it can be a bacterial pleural effusion or a malignant pleural effusion. To differentiate these two, you need a fluid cytology. So if there is a presence of malignant cells, that means that it is occurring as a result of malignancy. And further diagnosis of malignancy can be done by using thoracoscopy or CT guided biopsy. Moving ahead to another rare cause of exudative pleural effusion called as chylothorax. Here there is a collection of milky fluid within the pleura. Now this occurs primarily because of a damage or a trauma to the thoracic duct. Now thoracic duct is a structure which receives all the lymphatic fluid from all the lymph and drains into the superior vena cava. Now, whenever there is a damage to this thoracic duct which opens into the pleura, there is an accumulation or there is a drainage of all this lymph-rich fluid into the pleura. leading to a pleural effusion. When you try to aspirate this pleural effusion, when you do a thoracocentesis, you would get a milky fluid. Now, this usually occurs because of trauma. Now, trauma, what do we mean by trauma? It is usually a post-operative trauma. Trauma of the thoracic duct because of any operations of either a heart or any surgeries on the mediastinum. It is most commonly seen in coronary artery bypass surgery or any surgeries of aortic aneurysm or aortic arch repair. Now, this milky fluid will have a triazole glycerol of more than 110 milligram per dl. To diagnose it, you can do a lymphangiogram or a mediastinal CT scan. Now, this is an image where contrast has been injected into the thoracic duct, and you can see here that there is a leak of the contrast from the thoracic duct into the pleura, that is on the left side, which leads to an accumulation of left-sided pleural effusion. Now, the management of chylothorax is putting an intercostal drainage tube. Because once there is a damage to the thoracic duct, it will take its own time to heal. So a therapeutic or a diagnostic tap will not be the answer, because once you tap and remove all the fluid, there is soon a collection of pleura. There is a recurrent pleural effusion. That is the reason why you need to put an intercostal drainage tube. Octreotide has been used to reduce the collection, and for non-responders, you can do a thoracic duct ligation. So, how do you treat an individual pleural effusion? First and foremost, evaluate the cause and treat the cause. Because pleural effusion is a clinical disorder arising out of multiple etiologies. Next is a therapeutic drainage. If the pleural effusion is large enough to cause symptoms such as a mediastinal shift or a dyspnea or a cough or a pleuritic chest pain that is unbearable, you need to do a therapeutic drainage. That is the same way we do a thoracocentesis. Here we need to remove all the fluid, as much as the fluid that we can remove. And if there is a recurrent collection, so you might face a scenario where you remove large amount of fluid, as large as 500 to 700 ml of pleural fluid. Yet again, when you evaluate the individual, after 2 days, you can find again a large collection of fluid, depending upon the etiology. If there is a recurrent accumulation, or if you feel that accumulation is exudative, or if there is a pus accumulation, you need to put an intercostal drainage tube. And if the pleural effusion of exudative cause is because of malignancy or any other cause which will lead to a recurrent pleural effusion, as in case of asbestosis exposure, you can go for a pleurodesis by using sclerosing agents such as doxycycline. Now, moving ahead to the next kind of collection in the pleura. Now, we studied collection of pleural effusion, that is increased production of fluid, or a collection of chyle in the fluid leading to a chylothorax. Now we are going to study a collection of air in the pleural cavity, which is called as pneumothorax. Now, pneumothorax can be classified as either a primary, secondary, or traumatic. Now, primary or secondary also can be termed as primary spontaneous or a secondary spontaneous. Now, primary spontaneous is an occurrence of pneumothorax in an individual who has no history of lung disease. Now, in these individuals, they are usually tall and thin built. Here, the escape of air from the alveoli into the pleura is usually because of a rupture of small subpleural emphysematous bullae or subpleural bleb. Now, here, there is an escape of air usually in the apical regions. Because of this rupture of the subpleural emphysematous bullae, there is a slow escape of air from the alveoli into the pleural space. This is called as primary spontaneous. Here, there is no history of any lung disease. Now, what is secondary spontaneous? Secondary spontaneous means here there is already an established lung disease, usually a COPD or a tuberculosis or asthma or bronchiogenic carcinoma. These individuals who have already an established lung disease develop a pneumothorax. There is an escape of air because of either of a rupture of the affected alveoli. And third variety is a traumatic pneumothorax. Here, there is a collection of air in the pleural cavity either because of a chest wall trauma or iatrogenic trauma, either because of surgery in the thoracic cavity or biopsy. What are the clinical features? As I told you, any collection, be it an air, be it a chyle, or be it a fluid in the pleura, the most common clinical feature will be usually a cough or a pleurisy. That's a pleuritic chest pain. If the accumulation is large enough to compromise the expansion of the lung, that means whether the collection can be a fluid or whether the collection can be air, if it is large enough to prevent the expansion of the lung, it can lead to shortness of breath. As I told you, it can lead to pleuritic chest pain, typically associated with movements of the chest. Whenever the individual moves about or whenever he takes an deep breath, that individual can have an increased aggravation of this pain. There can be constitutional features such as fever. And as I told you, percussion is one important sign, because when you auscultate an individual with pleural effusion or a pneumothorax, there is a reduced air entry in both of them. Now, how do you differentiate it? Based on percussion. So when you do a percussion on individual with pleural effusion, you will find a dull note. And when you percuss an individual with pneumothorax, you will find a hyper-resonant note. So this is very important clinical sign for you to remember to differentiate an individual suffering from effusion and pneumothorax. Because just by auscultation, you can never differentiate. Because in both the situations, air entry is reduced on auscultation. It is the percussion that is going to differentiate. Then there comes a sign of tension pneumothorax. Now, tension pneumothorax is a physiology of pneumothorax where there is a valve-like mechanism. Here, the collection in the pleural space is progressive. That means that the valve is allowing the entry of air into the pleural space from the lungs only one way. During inspiration, there is entry of air into the pleural space, but during expiration, it is blocked. There is no exit of air from the pleural cavity. So progressively, slowly, the pleural cavity increases in size. It causes the collapse of that lung. It causes the shift of the mediastinum on the other side. And when it causes huge shift of the mediastinum and the collapse of the lung, it can lead to clinical features such as tachycardia, tachypnea. There can be hypotension also. So these three signs are very important for you to note an individual with tension pneumothorax. That is hypotension, increase in heart rate, that is tachycardia, and increase in respiratory rate, that is tachy. As I told you, a spontaneous pneumothorax, be it a primary spontaneous or a secondary spontaneous, exists in three forms, three physiological forms. The first form is a closed type. So here, what do I mean by closed type is, there is no communication between the pleura and the alveoli. Here, some amount of air has escaped from the alveoli into the pleural space. Now, the amount of air escaped is fixed. So, there is no more communication between the pleural space and the alveoli. So, the amount of air collected is not going to increase. Over the time, the amount of air is going to be reabsorbed and it is going to resolve spontaneously. So usually the closed type is a benign form, and here the pleural pressure, mean pleural pressure is negative. So usually this will not have any grave signs or symptoms. Moving ahead to the next type, which is called as an open type. Here there is a communication between the pleural space, which has got an accumulation of air, and also between the alveoli. But there is a free flow from the alveoli into the pleural space to and fro. That means that air can freely enter the pleural space and can also exit the pleural space. This type of physiology of pneumothorax is typically seen in individuals who have got a ruptured tubercular cavity or an emphysematous bullae or an lung abscess. So here it is an open type with a mean pleural pressure which is atmospheric. And the third and the dangerous variety, which is called as tension type. As I told you, here it acts as a valve-like. Here there is a communication between the pleural space and the alveoli, but it is a valve-like communication. Here there is only entry of air from the alveolar space into the pleural space during inspiration. During inspiration, air moves from the alveoli into the pleural space, increases the pneumothorax. But during expiration, the air in the pleural space do not escape. It is unable to exit because of the valve-like mechanism. As a result of which, there is an increased accumulation of air, which is progressive, which can lead to collapse of the same side of the lung, which can lead to a mediastinal shift on the opposite side, and can be an important cause of morbidity and mortality. As I told you, hypotension, tachycardia, and tachypnea are the important signs of tension type of pneumothorax. Here, mean pleural pressure is positive. It is more than the atmospheric pressure. So this is an individual suffering from large left-sided pneumothorax, which you can clearly see, a tension type of pneumothorax, which has shifted all of the mediastinum. You can see a shift of heart, a shift of trachea, which you can trace clearly on the right side. Now, this halo, the shadow, has got no lung markings. So this is typically diagnostic of pneumothorax. Whenever you find this kind of X-ray, you need to do an urgent percutaneous needle aspiration, which is life-saving in such individuals. So what is the treatment of individual with pneumothorax? Supplemental oxygen. By providing oxygen, not only you can improve the oxygenation, but can also improve the absorption of collected air. If the lung edge is less than 2 cm, it usually resolves. Or if it is a closed type of pneumothorax, it usually resolves. It usually absorbs. You need not do any other form of aspiration or intercostal drainage. If it is a life-threatening or a tension type of pneumothorax, you need to do a percutaneous needle aspiration. Insert a 21 gauge needle in the second intercostal space of the affected site. And this can be life-saving in an individual with pneumothorax. Never hesitate to put a needle in an individual suspected with pneumothorax. If there is a huge accumulation and if it can be drained easily, intercostal drainage is the option. An intercostal drainage tube is put between 4th, 5th or the 6th in the mid-axillary line and watch for reinflation of the lungs along with the bubbling. Now this ICD tube, which is put between the 4th, 5th and 6th rib, is connected to a Heimlich or a underwater seal. Now this underwater seal has to be watched for occurrence of bubbling. Now after 24 hours, usually lung reinflates because all of the air within the pleura is drained via the intercostal drainage tube. After the reinflation of the lung, bubbling stops. So you need to find the evidence that after the bubbling has stopped, there is reinflation of lung, which is confirmed by chest X-ray. If that is the case, then you can safely remove the intercostal drainage tube. Sometimes bubbling won't stop even for 5 to 7 days. So that means that is an indication for surgery. In some individuals, bubbling usually stops, but on a chest X-ray, there is no evidence or little evidence of lung reinflation. So that means that the tube must have kinked or blocked somewhere. So that is not an indication for removal of tube. That means that you need to reintroduce the patency of the tube. And consider surgical pleurodesis or thoracoscopic pleurodesis in an individual who is having a second episode of pneumothorax and an individual who is having a first episode of secondary pneumothorax. So an individual who is having a first episode of secondary pneumothorax or a second time pneumothorax in any individual gives you a green signal to do a surgical pleurodesis. To summarize disorders of pleura, pleural space lies between the lung and the chest wall, which serves as a coupling system. Collection of fluid in the pleura is pleural effusion. Collection of chyle is chylothorax. Collection of blood in the pleural cavity is hemothorax. And similarly, collection of air in the pleural cavity is pneumothorax. Clinical features are dyspnea, cough, and pleuritic chest pain. And on examination, there is a reduced air entry, dull percussion note in fluid collection, and a hyperresonant note in pneumothorax. Pleural effusion can be classified as an exudative collection by a higher protein and a LDH ratios to serum. One of three criteria, if they are met, then it is an exudative pleural effusion. Common causes of transudative pleural effusion are congestive heart failure, nephrotic syndrome, or cirrhosis. Common causes of exudative pleural effusion are malignancy, infection, in our country it is tuberculosis, and collagen vascular diseases. Pneumothorax exists as open, closed, or tension pneumothorax physiology. Common causes of secondary pneumothorax are asthma, lung abscess, pulmonary infarcts, bronchogenic carcinoma, and all forms of fibrotic and cystic lung disease. Management of pneumothorax includes oxygen supplementation, percutaneous aspiration, especially in individuals suffering from tension pneumothorax, and implantation of intercostal drainage tube or pleurodesis for second episode of all pneumothorax or first episode of secondary pneumothorax. So this brings us to the end of a learning on disorders of pleura. One important piece of knowledge I want you to learn is the importance of auscultation and percussion in the disorders of pleura. I would encourage all of my students to go ahead and do a percussion in an individual with a reduced unilateral breath sounds to diagnose whether it is a collection of air or a collection of fluid before you have a look into a chest X-ray.